Hello, everyone. I am Rutt Lindström. I am data standardization analyst, and my day job is in TEHIK, which is the Estonian e-health agency. And also have a hobby job in HL7 Europe, so I get to be in all the projects that are related to regulatory authorities, but at the same time also do other things that are related to wider standardization. What we're going to talk about today is European cross-border prescription first, the current implementation of it, because it's already an operational service. Then a short overview of what EU countries are doing in regards of ePrescription and eDispensation, what are the current tendencies, and then how we work towards the EHDS, of course. And starting from European cross-border prescription. So My Health at the EU is the collection of member states and the representatives who are actually in charge of European cross-border prescription and other cross-border services. Right now, there are 10 countries in operation with prescription and dispensation, and there are very many others who are in the testing phase. They are likely to be in operation very soon. It uses HL7 CDA, not FHIR. And the Open NCP software, which is for NCP stands for National Contact Point, so every country has a national contact point, and they use a certain software, which is also by European Commission. It's an open source software. And it has a long history, so let's look at the history line. So the EU cross-border prescription, it actually starts from 2008 with EPSO's project, which was creating specifications and also the software for cross-border e-prescription, but also for patient summary. So the international patient summary that we know today actually started from that project. But for e-prescription, I need to confess now, in 2008, and it was a 6-year project, so it went on for a long while. I was working at the time in the medicines agency in Estonia, and I remember a meeting where the e-health agency came to us and explained their idea, or the European idea of cross-border prescriptions. And I remember us sitting there and yeah, like that's ever gonna work, there's no way. And of course, years passed, and the EPSOs had their first successful pilots, but then it was kind of put on hold before it was ready to go operational. But the specification is from that time, the first specification and the way it works, so that's why it's CDA. So even though My Health at the EU actually went into operation in 2019, and I think some people were already closer to FHIR, or at least countries who are joining now would maybe want to do that on FHIR. The specifications date back so long, so it's inevitably CDA. And 2020, I started working with the eHealth agency, and my first job was to do the semantic work for cross-border e-prescription, so I was happy and sad to be proven wrong. But every now and then, because now we're in 2025 and we have a lot of questions about is EHDS actually going to work, and it seems like impossible. So I try to hold myself back this time, yeah, it might work. It has worked before, it just takes time. And how the cross-border e-prescription works. It's this is a gross simplification. But basically, you have a country A that has a national contact point. You have a country B, which is a national contact point. So we have Estonia and Portugal, and you want to send the prescription over. So first of all, you need a prescription. So where Estonia has this very legacy system of prescriptions, the prescriptions are in Estonia, they use their own terminology, and they have their own custom structure. It doesn't even use CDA or anything. And then the first step is that we transform this structure to the European common structure. You see on the slide there that we have EU structure, but it's still in Estonian using our terminology. So the step 2 is that we actually match it to European value sets. Master Value Set Catalog is the acronym MVC that people use and expect everyone to know, but hardly ever anyone knows what it means. This is our value set catalog. And then we get it's in English, it uses the EU agreed terminology, and it uses the EU structure. And then in Portugal, their national contact point then translates the prescription. And they have translations for all the EU value sets, so they just sort of use that translation. They do not necessarily map it. It is allowed to map the cross-border documents to match their into your systems, especially for dispensations. You usually want to record the dispensation in your system and you may have to map it. But for ePrescription, usually they just show it. For patient summary, for example, we don't actually recommend mapping because every mapping creates some data loss. So if you have the first mapping there in the first stage and then the second mapping in the second stage, you might lose too much data. And the cross-border services, it's not like country joins and everything is available. So this is just an example that it's a very complicated matrix, which countries are operating on which services with which other countries. So this is just patient summary and ePrescription, eDispensation, but you can see there is a matrix there who is talking to who on what level. And this service has some restrictions. There is a cross-border healthcare directive that restricts this service to avoid drug trafficking and ensure patient safety. So there are some common rules. For example, the narcotics prescriptions are not allowed cross-border, but every country can actually add their own restrictions. So here is just an example that Estonia excludes this list. Finland has this list. And there are several reasons why a country might want to exclude something. So for example, if you are unable to, like I think a good example here, and it causes a lot of problems in Estonian pharmacies, is this kind of prescription here. It's a prescription that has a time period instead of amount for the like how much medication is allowed. It's a repeat prescription. You can dispense it several times, but it only works if the pharmacist can see all the dispensation that has been done before, and then they can sort of estimate, is this yearly amount already full now or not? So it's a time limit. And this would give a very good opening for drug trafficking. If you had a prescription like that, then you could just like dispense it forever and in God knows in which amounts. So these are restricted, they're not allowed cross-border, but patients are not happy. So again, like EHDS, if you already know that we are have to do these things cross-border, then if you are now would implement your new prescription system, you would obviously think about these things already. And the code systems used in cross-border are these. I'm not going to read them to you, but an important thing to notice is that there is no SNOMED here. And I would like anyone who wants to see SNOMED, for example, in EHDS specifications, to come to us and say, like, we don't like these, or we want SNOMED to be added. So right now, this is what it is. And on cross-border level, it's very difficult to actually understand if you're doing a substitution of a drug, or is it just that the drug information is represented differently? This is a nightmare example from cross-border again. So Ozempic, very popular drug, and it was cheaper for Finnish people without the reimbursement to buy it from Estonia, so it was very popular. But because the package representation was different, it used up their whole limit on their prescription. But actually they were just one pen, but their system showed that they got several, just because the pack size was just displayed differently. So, and Finland, Estonia, Portugal here, they all represent this pack size differently, and also the strength presentation can be different. And we cannot solve that on ePrescription side. This is something that medicines agencies need to fix by themselves, and there are projects for that as well. And working for EHDS and the new specifications, we looked at what countries are doing right now. So the overall status of ePrescription and eDispensation on FHIR. And most countries who we talk to, they have steady ePrescriptions systems already in place. And they date back a long time. It has a lot of workflow logic into it. The requirements are very deep in the legislation. It's very difficult to actually change the existing ePrescription system. So, but they are, a lot of them at least, are working on a FHIR facade on this prescription system. So they're keeping the old system, but they're just creating a FHIR facade to that. And what I think is interesting to notice is that very many countries are actually working on medication lists. So they're not working on just new prescription systems, but medication lists which would sort of enlist the treatments rather than individual prescriptions, and the prescriptions are sort of pushed somewhere back of the system as logistical items, and they're not like the clinical information anymore. Multi-item prescriptions. In FHIR, medication request only allows one medication per request. What we see is that in Europe, majority of countries actually allow multiple items on a prescription. So for the EHDS, we need to come up with a solution for that. How do we do that on FHIR so that we would all be doing that in the same way? And health information on prescription. So ISO prescription standard also says like there should be quite a lot of health information on a prescription. I think the Netherlands has quite a lot of health information on a prescription. And at the same time, we have most countries don't even want indication on a prescription, or at least they don't need it. So again, there are some countries who absolutely require indication and some who think it should not even be there because the pharmacist doesn't have to know. It's different by countries. And of course, the classic, so the statuses and workflow, if you look at the medication request statuses, if you look at the actual prescription systems that exist and how they manage the workflow and statuses, it's very different. So it's very important to connect the prescription work with the HL7 FHIR workflow work. So it's not enough to just implement medication request. You need to look at the full workflow. And the nice example here is actually, it's unreadable, I see, but it's from Slovenia, and we did a lot of work with that. It was a really good example to show the whole complexity of actual prescription systems. And what we expect from EHDS, starting from the scope. Again, prescriptions are defined very differently in different countries. So we did some homework to find out what EHDS expects us to have in scope at all. And after reading, and then there are some red lines there. In scope for EHDS, specification is a prescription for medicinal product. So it's not devices or anything else, it's a medicinal product. It's issued by a health professional. It's for a patient, and it's dispensed by a pharmacy. So device-device interactions or things like that and hospital use is actually out of scope for EHDS. And the dispense is, again, of a medicinal product by a pharmacy, including online pharmacy, which is very important. It doesn't actually make a lot of difference in the specification itself because the data elements are the same mostly, but it's important to see that as one of the important use cases also for cross-border. If you put cross-border and online pharmacy together, it opens up a completely new market. And the dispense is for a natural person, and it has to be based on a prescription. So again, like over-the-counter dispenses, you can, of course, use our specification for that, but it's not strictly in scope for EHDS. And in addition, there is a borderline case that we decided that is included unless somebody objects, and it's declining a dispense. So in case you have a prescription and the pharmacist decides, no, like there's something wrong with the prescription, or they have some other doubts, they can just like explicitly send the information back that no, I'm not dispensing this. And out of scope, some of the things that are out of scope for us, like hospital use and workflow, are actually in scope for the IHE, medication, prescription and dispense profile. And we expect to leverage on that as well. And reimbursement is out of scope because we also looked into it and the countries were doing it just so differently. So for EHDS, we have all those things that I mentioned are addressed. Multi-item prescriptions, indications are optional, so on, so on, so on. We try to be very flexible to make sure that countries can use this for their FHIR facades as well. And we actually do have a ready-made implementation guide, which you can all look at. It uses FHIR R4 and R5 both, so you can move between versions. And it was a collaboration of many countries, and also IHE Pharmacy, HL7 Europe were on board. And if we had a session yesterday, will there be less implementation guides with EHDS, then I can reassure you that there will be enough implementation guides for everybody. So this is the current status for just medication prescription and dispense, where we have the HL7 Europe FHIR IG there in top middle. It has R4 and R5 versions. We have the IHC global profile. We have the logical models implementation guide that is on the side. We expect national specifications to use either R4 and R5, which one they need. My Health at EU, it doesn't have the FHIR implementation yet, but if they will more likely be using R4 because the current ones are using R4, and then there would be transformations from the national ones. So it's a mess, but it's a beautiful mess. And you can all come to our ballots. So IHE MPD, there's only a few days left for the IHE ballot. HL7 Europe is only starting, and also extended EHR stakeholder consultation is running in parallel because the FHIR implementation guide is, for us, common. Thank you. Question?
Thanks, Rutt. Anyone questions?
Rutt, you said the problem with the indication, or every country has a different opinion. Would giving access in parallel to the patient summary, could this address this to a certain degree?
That is our opinion, that if you need to show your pharmacist a certain set of health information, it's better to do that with patient summary or with something else on the side. So it shouldn't necessarily be on a prescription itself. But we are not restricting that. If a country wants to add these things, they can, but we are not doing anything to enforce that.
Thanks, Rutt. That was a great presentation. Would you like a policy question or a technical question?
I can have both.
Okay.
Because I was running so fast to make sure we have a few minutes.
Awesome. All right, the policy question is, how do you harmonize the different medicines prescribing policies in the different countries in a cross-border solution like this? And the technical one...
wait, can I have this one first?
Yeah.
So the answer is we don't.
Awesome.
Yeah. So right now there is no initiative to harmonize prescribing practice on a policy level. I think it will inevitably happen, but there's nobody actually enforcing this.
Noted. Thank you. The technical question was on the indication again. If you've got a prescription from one jurisdiction that has the indication going to a jurisdiction where they explicitly exclude it, does the transformation then remove it before it gets displayed on the other side?
So yes, right now cross-border prescription does not have indication. So if you have indication, it's always removed.
We have time for 2 more questions. Anyone?
Hi, thank you for the presentation. So I'm not so familiar with the EU model of prescriptions or ePrescriptions. So do the prescriptions get sent from the clinician to the pharmacy, or does that get sent to the patient first and then the patient manages how that gets sent?
So that's probably different by countries. But the way cross-border works is it doesn't really care how it operates in a country. So it's 2 national contact points talking to each other. So the pharmacy, the patient goes to the pharmacy, identifies themselves, and the pharmacy system needs to contact the national contact point in their country, and those national contact points need to do what they need to do. So every contact point needs to know what happens in their country, but it is not possible for everyone to know like what happens in others or how these things are handled.
Just following up on that one, how does the prescription enter into the system?
Like as a national prescription. Like there is no cross-border prescribing Cross-border prescription happens from national prescription is taken and transformed into the cross-border format.
So in the EU, all prescriptions are recorded electronically?
The ones that you can send cross-border are recorded electronically. So it's different by countries. Like in Estonia, I have actual colleagues who have never seen a paper prescription. So these are adults. That's how long we've had only digital prescriptions. But there are other countries who are like, for whom this is just the beginning.
That would be the last question.
Yep, thanks. Can you elaborate a bit on there's no cross-border prescription? So if something would happen to me from Finland right now in Amsterdam, I'd go to a clinic, I'd get a prescription that would then need to be continued in Finland. How that would work out?
That does not work out right now because the national contact point only recognizes you when you're like in their patient registry. So right now, prescription and dispensers only work one way. So if you have in your home country with your ID something prescribed, you can buy it in another country, but it doesn't work both ways. With EHDS, it should work both ways, but I don't have the answer how it's going to happen. Yeah.
Now that is the end of the presentation, and thanks a lot, Rutt, and let's give her a round of applause.